Everybody, once again, welcome to Samaritans Purse International Health Forum. I appreciate everybody joining us today. As Tom has already mentioned, we will be speaking, as you can see, about post-exposure prophylaxis. And I have a daunting task to get all this in the next hour or so, but I'll do my best. If you have questions, please feel free to chime in. Post-exposure prophylaxis, as you all well imagine, is a very important topic matter. And as Tom said, we are in the process of completing our protocol and going to get that out to the field internationally in the short future. What is post-exposure prophylaxis? We'll be discussing that in just a second, giving a definition, but just starting off, as you can imagine, there are very obvious grave consequences that can occur from exposure to both blood and body fluids from various means, like needle sticks or various injuries that can occur from sharp medical instrumentation, certainly from sexual assault that could potentially happen as well. The big risk, the big three viruses that we worry about, as you can see, are HIV, hepatitis B, and hepatitis C. And we'll talk about their infectivity rates and what can occur, how they can be transmitted. So as I said, post-exposure prophylaxis, what is the definition? And basically, it's preventative measures that we can take in a very timely fashion to prevent the transmission of infection after an accident or traumatic exposure has occurred. So the big question is, what are the risks? Starting off just looking at HIV, with HIV transmission, that's the virus that everybody worries about. But really, I'll say HIV is, I'll remember one of my professors at medical school at Chapel Hill, he called it a wimpy virus. And what he meant by that is it's actually, you've got to usually work pretty hard to get HIV. Relative to hepatitis, certainly B and C, it's not nearly as infectious. As I've written here, the average risk of HIV transmission following percutaneous exposure is about 1 in 300 or 0.3%. So even under the right circumstances, if you will, when you get stuck with a needle that's from a patient that's HIV positive, the risk is still pretty low that transmission can occur. But should that happen, obviously the consequences are dire, so we want to take proper precaution. In terms of hepatitis B, the risk of transmission for hepatitis B in an unvaccinated healthcare worker, let me stop right here. Samaritans Purse certainly advocates that all healthcare workers be vaccinated against hepatitis B, and I'm sure you must be. But also the big question, and we'll talk about this, is do you know what your hepatitis B surface antibody titer is? You may have been vaccinated for hepatitis B, but you could potentially be a non-responder, and so you're not protected even though you've been vaccinated. As I said, with hepatitis B, the risk of transmission is much greater than it is with HIV. Hepatitis B, as I've written there, is about 50 to 100 times more infectious than HIV. And then finally, looking at the bottom there, the risk of transmission for hepatitis C, it's about 6-fold greater than HIV. Post-exposure prophylaxis, the definition of an exposure. What is that when we say exposure? What is that? So contact of a healthcare professional with a potentially infectious exposure to blood or body fluid via a mechanism or injury or assault that increases the risk of these three viruses. Some of the potential mechanisms or injuries in which this transmission can occur are like needle sticks, lacerations with a sharp medical instrument, contact of mucous membrane with or non-intact skin, and then again sexual assault. Let me point out, I underlined non-intact skin. Really, if a person were to be exposed with blood or body fluid that is seropositive for one of these viruses, if it gets on intact skin, the risk is essentially zero. So, I mean, it would be, not a good situation, but the risk is essentially zero. So it really has to be non-intact skin. And I just might add, this is kind of heavy topic matter, and so for little commercials, if you will, I've just added some pictures of places I've been throughout the years. This is just a pretty graphic picture, if you will. These are the skeletal remains that we saw of a victim of the Haiti earthquake in 2010. So pretty intense time. So in terms of getting back, when we talk about body fluids, what are the body fluids that we are most concerned with? Of course, blood is primary, and then after that, any blood-tinged body fluid. So if you have any fluid from the body that's been contaminated with blood, that's certainly going to be potentially infectious too. And then, of course, semen or vaginal secretions, they certainly can have a high viral content and be infectious. Fluids which are usually not of concern, unless again they're tainted with blood, would be urine, feces, saliva, gastric secretions, and vomitus. And some of those surprise me, but those are usually okay if we get exposed to those. At least we won't be transmitted those viruses. And then questionable body fluids, those that are potentially infectious, would be cerebrospinal fluid, pleural fluid, so that's fluid from the thoracic cavity, peritoneal fluid, that's of course fluid from the abdominal cavity, then amniotic fluid, pericardial fluid, fluid from around the heart, and then synovial fluid, that is fluid from the joint space. All those are potentially infectious, but not as worrisome as, again, like it certainly is blood. Yes. Did someone have a question? Okay. So in terms of the risk of transmission varies significantly depending on the nature of the exposure. Let me elaborate about that. What are the various factors that can increase the risk of transmission? I've written 6 here. There's several others, but these are the primary factors. Number one is certainly the deeper the injury. So let's say the deeper the needle embeds obviously into your extremity, the more likely or the higher the risk of transmission. Certainly a hollow bore needle is more risky than a solid bore needle. And then a large viral load. So if you've got a patient, let's say, that has advanced age and their viral load is quite high, that's going to be a lot riskier than, say, a patient that has HIV disease that's been well regulated with antiretroviral therapy. And then if you have a device that is visibly contaminated with blood, certainly that's more concerning than you have an instrument that has very, very little blood content on it. And then if you do get exposed with a needle that came directly from the source patient's vein or artery, that's of course a big concern. And then, as I've already alluded to, if you have a source patient that has a terminal illness from advanced AIDS or viral hepatitis, then those are all going to increase your risk for transmission. And if just might add, as I'm moving along here, if y'all have any questions, you see the little icons there. Just can they see this, Rich?
No, when you click it, they can.
Okay, so I'll just click onto that. If you just click onto that icon, am I getting it?
Yeah, it's up there. You can see it up top.
Okay. Then that raises your hand, and I will call on you. Or honestly, just feel free to ask a question. But moving along there, in terms of looking at some professions, I really wanted to point this out to all the nurses here. You all are at the top of the list in terms of highest professional at risk for transmission. So that's one time that you don't want to be in first place, but I'm afraid you are. So it's really prudent that you all really exercise all the precautions you can to prevent transmission. And then I can read for yourself there, but after that it would be residents, no surprise, and fellows, those doctors that are in training, followed by attending physicians, and then followed by that, non-lab technologists. I'm not sure exactly what that means. I'm assuming that means phlebotomist. I couldn't find a definition, but I'm assuming that means a phlebotomist. I would think they would be highly at risk. And then after that, respiratory therapists, and I imagine because they get a lot of like arterial blood gases and things of that nature, so they certainly would be at risk. An interesting comment here, it says there has never been a confirmed case of HIV transmitted to a surgeon through occupational exposure in the United States. So we certainly worry about our surgeon friends, but that is rather assuring there. So really, they're not at the top of the list. Again, it would be nurses would be number one. And then one other comment before I move along there, one other element that's really critical is that it tends to happen in professionals that are fatigued. Unfortunately, those go hand in hand. Oftentimes, healthcare professionals are overworked and are fatigued, but that certainly puts you at risk. So when you are sleep deprived, you need to be especially careful.
Chad asked, what about medics?
What about medics? I didn't see them on the list, Chad, but certainly you guys being out there on the field so much, drawing blood and being directly in contact with people that have been traumatized, you're certainly at risk. So you certainly want to exercise universal precautions with proper gloves and gowns and so forth. Didn't see that on there, but I'm sure that they're up there.
There's only one funny-looking guy in that picture.
Yeah. Here's the three amigos. I thought we all three looked very similar, but anyway, you'll meet some amazing people out there on the field. This guy, well, both of those guys were great guys, great character. So the sequence of events following exposure. So let's say that we do have a healthcare professional that is inadvertently exposed. What is the step-by-step process that we should take? And I've written out a sort of a simple four-step process, and we'll elaborate after this slide. But step one is, of course, you want to thoroughly cleanse the exposed region that was that region that was exposed to the instrument. Step two after that is careful documentation. And I'm not going to elaborate a long time about documentation today. I will, again, make reference to our protocol in which we go to great lengths to elaborate about that. But one important comment I should make about documentation is that the process really should not delay the remaining steps. So really, I think one thing you could do is you certainly could team up and you could have one person making all the documentation while the other person is progressing forward, because it is critical that as we provide post-exposure prophylaxis that we do so, again, in a timely fashion. Step three is, of course, you want to make sure that you have proper and expedient diagnosis, and so we'll talk about the various laboratory assays that we need to perform. And then finally, of course, you want to intervene with proper treatment, again, in a timely fashion. So let's look at step one, thorough cleansing. So, of course, you want to immediately cleanse the exposed site. And it's really nothing too sophisticated. With skin exposures, like if you have, for example, a region of abraded skin that got exposed to blood or body fluids, you want to use copious water and soap and cleanse it very thoroughly. If we're talking about punctures, you want to cleanse, or punctures are like a much smaller wound. You want to utilize an antiseptic, and what would be ideal would be an alcohol-based antiseptic, as all three of the viruses that we are making reference to, HIV, Hep B, and C, are all they are killed by an alcohol-based antiseptic. And then finally, mucosal surface exposures, you want to, again, flush with an abundant amount of water. So just continue to really cleanse it thoroughly with significant water. In terms of documentation, again, I'm not going to spend but just a few minutes because I've got a lot of other important issues to discuss. But again, refer to our protocol, which we will be disseminating shortly to the field. But with documentation, of course, you want to provide the name and identification of both the source and exposed patient. So, of course, the source patient is the patient that is potentially seropositive for the viruses, and then the exposed patient, of course, is the healthcare worker. You want to time and date the document. You want to give a very detailed elaboration about the event, the where, the when, and the how. What were the circumstances around the exposure? What is the fluid type we're referring to? Where was the exposure? Did it occur? Was it, did they get exposed in the eye? Their conjunctiva was doused with blood, perhaps, or did they receive a needle stick in the arm? There's a lot of different scenarios. What was the depth of the injury, exposure time, the quantity of fluid, real detailed information. Of course, also with the source patient, you want to really provide detail. What are their risk factors for HIV and hepatitis? And did they have a history of laboratory assays? Have they been evaluated in the past potentially for HIV or Hep B or C? And then also, we would assume that the exposed patient, the healthcare worker, is not seropositive, but you never know. So you certainly want to inquire with them as well about what's their prior history for these viruses and have they been tested in the past. And then finally, in terms of the source patient, again, you want to know a little more detail about him. If he is he or she is HIV positive or hepatitis positive, do they know their viral loads? Do they know CD4 counts? Have they had a history of resistance? That's going to be important when you're providing treatment. And then, of course, you want to detail the physical exam, the focal physical exam. You guys are awfully quiet out there. I must be doing a very good job. Again, if you have questions, we're pressed for time, but you certainly can ask them. Step three is diagnosis. So we're going to look at each virus individually, starting off, of course, with HIV. In terms of the source patient, what we want to do first is we want to perform a rapid HIV. And first, again, if they're, you inquire if they're historically HIV positive or not. If they say no, we would proceed forward with a rapid HIV test. If it is positive, at some point it would be ideal to confirm that with a Western blot. Usually there's different assays that they perform rapid HIV assays with, like ELISA is one. And I must say these rapid HIV tests, their sensitivity and specificity over the years have progressively improved. So it's almost getting to the point perhaps where we don't even need to use a confirmatory Western blot, but that is still recommended. I want to point out one other important point. This has rarely occurred, but if you do have a source patient that has primary disease or acute antiretroviral syndrome, then they could potentially test negative when in fact they're positive. So if you have a high clinical index of suspicion that they have a primary HIV disease, then you would need to check for HIV RNA. Again, that's a very rare circumstance, but that's a potential possibility. And then looking at the exposed patient, you obviously want to evaluate them with a rapid HIV assay as well. You'd like to do that at baseline, at 6 weeks, at 3 months, and then 6 months. And again, if it happens to test positive, we would confirm that with a Western blot. You would sure hate to tell someone that they're HIV positive and it end up being a false positive. Unlikely, but it's possible. So we want to do a confirmatory test, Western blot, which is very specific. One other little aside is during that 6-month window of evaluation, you want to make sure that the exposed patient, should they engage in sexual intercourse, that they utilize condoms. It's an unlikely event that they did acquire HIV or hepatitis. We would sure hate for them to pass on that infection to their marriage partner. So the next virus, hepatitis B. For hepatitis B, post-exposure prophylaxis is determined by the, and this is an important point, the prophylaxis that we will provide, it is determined by the hepatitis B surface antigen status of the source patient and the vaccination and vaccination response status of the exposed patient. That's what's of most concern, because that's going to direct how we manage, how we provide treatment. So again, you're looking at what is the surface, hepatitis B surface antigen status of the source patient, and the vaccination and vaccination response status of the patient that is exposed. So the first thing we want to do then is test the source patient, again, for hepatitis B surface antigen. Let's see, right there. We want to test the source patient for hepatitis B surface antigen, and ideally within 3 days. You'll read some protocols that say up to 7 days, but if we want to institute timely therapy, we have gone with 3 days, so we want to get that done quickly. And then if the source patient is unknown, that is, they don't know what they're, if perhaps they left without us testing them, or if they are surface antigen positive, that is, if they have active hepatitis B. So I want to make that point. If someone has active hepatitis B, they will be surface antigen positive. So if our source patient, then again, if they got away without us testing them, or they happen to be surface antigen positive, then the exposed patient who has undergone vaccination for hepatitis B in the past, but they do not know his or her hepatitis B surface antibody titer, then we need to do that and check that titer in a timely fashion. So let me stop here so I can make this point. So for everyone out there, I imagine everybody out there has probably been vaccinated for hepatitis B, but do you know, have you ever, subsequently thereafter, have you ever gone and had your surface antibody titer checked? If you haven't, I really encourage you to do that, because there are, again, people that are called non-responders. That is, they've received vaccination for it, but they've never mounted sufficient antibodies to protect them. I know a surgeon that's been vaccinated 3 times and still doesn't have sufficient antibodies. So it's important for you to know that. Don't practice out there with the false belief that you've been vaccinated and that you're absolutely safe.
What does that cost?
I don't know, actually. I don't have. Anybody have any idea? Hopefully, I can't imagine that insurance would not provide that for a healthcare worker, but we are in these times, so maybe they wouldn't. But I would say it would be worth a lot of money to know that. Looking at hepatitis C, so what we want to do is we want to test the source patient immediately for hepatitis C antibody to see if they're positive. If the and then it says in terms of the healthcare worker, if they're exposed to a confirmed source patient that is positive for hepatitis C, or as I said, if when the source patient is either potentially positive or it's unknown, in other words, again, if the source patient got away from us without testing, or we know that indeed they are positive, then the healthcare worker that was exposed should have the following baseline test and follow-up testing. At baseline, the exposed healthcare worker should have a antibody for hepatitis C. They should have hepatitis C RNA checked, and then they should have this simple liver test called an ALT. And then you want to, at 4 to 6 weeks, you want to just check, and let me back up a second. The reason why you want to check for hepatitis C antibody at baseline is because you just want to see, does this, maybe this healthcare worker has hepatitis C and they didn't know it. There's a lot of people actually that do carry hepatitis C and don't know it. So you just want to check at baseline, do they have hepatitis C? And then you want to get their baseline hepatitis C RNA value and their ALT. And then again, in 4 to 6 weeks, you want to follow up and check their hepatitis C RNA value again, because if they do start to seroconvert, that value is going to start climbing up significantly. And then finally, at 4 to 6 months, if they did get exposed to hepatitis C, at that point they will seroconvert and they will have developed anti-hepatitis C antibodies. So that's why at 4 to 6 months, with the exposed healthcare worker, they want to again check their hepatitis C antibody and check their hepatitis C RNA. With real active disease, that RNA value is going to be very high. And then, of course, you want to check your ALT too, because if you have active hepatitis C, then that's going to cause inflammation in your liver, and that ALT value will subsequently increase as well. So those are the tests that need to be conducted for hepatitis C in the exposed patient. So I'm going to stop right there a minute, and I'm going to quiz everyone. Looking at our poll question now, the question is, just one second here. It says there currently is no PEP treatment for which of the following viruses: A, HIV, B, hepatitis B, C, hepatitis C, or D, all of the above. Since there is no treatment, there is a high likelihood you could become seropositive to either of these viruses after a healthcare-related exposure. So, if someone gets stuck with a needle, which of the 3 viruses is there currently no post-exposure prophylaxis treatment for?
And if you look at the top of the participant list, you can see the little A with a box on it, and you can register your vote A, B, C, or D. In the participant list, just above the top person's name there, you should see next to the emoticons, A, B, C, or D. Just roll over that box with a letter in it.
You can cheat and see what other people do.
Yeah, now, you can cheat and look and see what everybody else is putting.
Close your eyes, Tom.
Yeah. See votes from Mary Lou and from Chad. Kelly and Mark have voted in the chat window. That's fine, too. Looking for some other votes out there.
So if Mary Lou Fisher says the answer is C, then I say the answer is C. That's right.
Noble of you.
Yeah. So that is exactly correct, and we're going to talk about that in a few minutes. Here's one of my buddies, one of my friends I made at Yida refugee camp, and this kid made an incredible recovery. I mean, when he first came in, he was a walking skeleton, and he hasn't fully arrived yet, but he's certainly on his way, and just a beautiful kid. It's they will grab your heart. So we're at step 4, and actually I'm moving a lot faster. So if you guys have questions, please feel free. So in terms of treatment, we'll start off with HIV. When a healthcare professional is exposed to blood or body fluids from a source patient who is known to be seropositive for this virus, then of course immediate initiation of PEP treatment is recommended. In this scenario, PEP should ideally start within 1 to 2 hours, and it's been said that the benefit decreases substantially after 24 to 36 hours. So the window of opportunity is pretty short, so that's a day, day and a half. That sounds like a long time, but for all you guys that have been out on the field, that's not a lot of time to get access to these, I would say, really specific antiretrovirals and get them in the person quickly. So ideally, again, within 1 to 2 hours. So that's why it's really paramount that we have these post-exposure prophylactic kits out on the field. And then if the healthcare professional is exposed to blood or body fluids from a source patient whose HIV status is unknown, then the PEP treatment is started while awaiting results when the source has known HIV risk factors. So let me say that again. So if you get exposed and you get tested, you do the rapid HIV assay. If you're waiting and you know that this source patient, let's say he's a known IV drug user, then we're going to start treatment. We're not going to wait around for the test results. We're going to go ahead and get started and test them. And go ahead and start treatment, start therapy while we're waiting for the test results.
Now, Lance, didn't you contradict yourself there a little bit? Because you said that if he's got all these bad signs, we're going to start treatment. But here you say you start treatment whether they have any signs or not to begin with. If we don't know what they're...
Well, I just said, okay, let's see, at the top I say, let me read what I said. Let's see, when a healthcare professional is exposed to blood or body fluids from a source patient who is HIV positive, right, then you start immediately.
Right.
But now I'm saying, down here, I'm saying, if we're exposed to a patient with blood or body fluids and their HIV status is unknown,
we still start.
Then I'm saying that if they have risk factors, so I don't know this guy, I just got stuck with the needle from this guy, and I don't know if he's HIV positive or not. But I know he uses IV drugs, and so that scares me. So I'm saying start therapy immediately while you're waiting for test results.
Okay, now if you were in Haiti,
yes, sir,
and didn't know this person,
start. It's I don't want to disparage Haiti, but yeah, the incidence in Haiti of HIV is so high that that's a judgment call, and there's certainly judgment calls within this, that you have to make. But I would say because the incidence of HIV is so high in Haiti, or whatever country you're looking at, that's something that would behoove us, to know. Then I would say, yeah, let's go ahead and initiate therapy while we're waiting. Do I have a question?
Yeah.
Let's see here. Does someone have a question for me?
In your chat room.
Oh, I'm sorry. I would think wasting and TB or both would be enough to trigger concerns for HIV seropositivity. I absolutely concur, Mark. Yeah, if I saw that, there's no question. I would not wait for the test results. I would get started. So, very good point. Let's see here. It says, Jody saying, I can see it would be easier for a healthcare professional to access the treatment within 1 to 2 hours if they are based in a facility. What is the plan for healthcare professionals and field staff who are in remote field locations? Jody, we are, as you questioned, we are in the process of assembling PEP kits, and high-risk remote locations like Boone Hospital or Gita, we're going to distribute kits directly to those venues so that they don't have to wait around. So it's needed. It's been needed for a long time, but we have just completed the protocol, and we are going to dispense those kits to the field. Very important question.
Yeah, the other thing about that, Jody, and to remember is, for our field locations, and all of you who are in work where you have these remote locations, we are, where we probably won't have kits in every office because there won't be people trained there in order to maintain those kits. We will have kits located in areas where they can be rapidly accessed, by flying a kit in on a plane or having it carried in on the plane or getting the patient out to the kit. But for those places where there is the high risk of exposure, where we actually have healthcare work going on, we will have kits in the hands of those providers, plus backup kits in the headquarters.
Okay. So I think we're clear on that. So continuing in regard to treatment for HIV, if the source patient does not have known risk factors, then the treatment can be delayed as long as the test results for HIV are available within 2 hours. So if you anticipate that it's going to take a good bit longer than that, then I'd go ahead and get started. Especially out in some of the places we work, and you're just not going to know really what their risk factors are. So I would, and it is a judgment call. And one of the things you definitely have to take into consideration. You do want to take into consideration the healthcare professional that's been exposed. What is their You want to get input from them because that's important, because most of these people are educated, are fairly educated about this subject matter, but you're weighing the risk of transmission versus the risk of side effects from the drugs. And this is just a little, and I would say that these drugs are, I would, if I had any question at all, I would err on the side of taking the drugs, but they're not, but there are potential risks. Like, for example, one of the most commonly utilized drugs we'll talk about in a minute, tenofovir. A known risk factor for that is renal failure. And in fact, I know there's actually a surgeon has volunteered a good bit with a World Medical Mission, and he actually got exposed and he took a regimen. I'm assuming it was tenofovir, but he's gone into renal failure and he's in real trouble right now. He's hospitalized as we speak. So that's the real big judgment call you have to make, the risk of transmission versus the risk of side effects. And again, I will say that's very unusual, and it's just coincidental that that's going on right now as I give this lecture. But they are, they are a real risk.
Yeah, Lance, with if you are going to go ahead and give to start, if you're worried about the fact that this person that you got exposed to don't know the results, and you go ahead and choose to start, what are the risks of the side effects of one treatment versus, the long-term treatment? If prophylaxis you can do just once, no, you're going to do more than once. But, so if you start and you say you find out they're negative and you stop, then, what are the risks associated with that?
I think what you're saying is, and we're going to talk about the treatment protocol, is a 28-day protocol. We're going to get into that in just a moment. But and I can't tell you, but I would say overall for serious complications, it would be, I'd say less than 5%. It would be very low. Now, the common side effects like GI side effects and things like that are very common. That is true. But serious complications
ones are 5%.
I said less than 5%, but that's a guesstimation on my part.
Yeah.
Well, I started to say less than 1%. No, I didn't say 5%. I said less than. I was playing it safe.
Yeah.
So I said less than 5%. But I would say probably below 1%. Let's see. If the source patient is unknown, then the PEP treatment is generally not started unless the event occurred in a context in which the HIV exposure is probable. And I gave this example is identical to what Dr. Bransford just mentioned. For example, geographic locations in which the baseline incidence of HIV is high. Well, in Samaritans Purse, that's about 90% where we're at is a lot of times. And it's true that in populations and in countries in which the socioeconomic status, the overall economy is rather low, the seropositivity is high. So I would, again, if it were me, I would err on the side of precaution and taking therapy.
Not so much because...
moving on, in terms of treatment for HIV, it says the duration of therapy, as I just mentioned, was 28 days. Pretty commonly now, most organizations are recommending, like for example, World Health Organization and CDC, they're recommending 3-drug antiretroviral regimens are now preferred for all PEP therapies. And generally that would include 2 nucleoside reverse transcriptase inhibitors plus a boosted protease inhibitor. If the source patient is HIV positive and he has a history of drug resistance, then I would really quickly refer to an infectious disease expert, as you likely want to modify your therapy based on that source patient's history of resistance. And then finally, patients receiving PEP treatment require laboratory monitoring. And in general, and this is again for potential drug toxicity, but ideally or generally what's recommended is a CBC with differential, Chem7, and LFTs at baseline, 2 weeks and 4 weeks. I certainly acknowledge that at times we're going to be in locations where that is not possible, but that is, again, ideal. Jody asked, what level are you counting on as high? So can you put that in the context again for me, Jody? The prevalence rate, well, going back to the question, so when I said high, what I said is, it was in reference to this last statement. It says, if the source patient is unknown, then PEP treatment is generally not started unless the event occurred in a context in which HIV exposure is probable. So, in other words, geographic locations in which the baseline incidence of HIV is high. So, I'm not sure if I'm going to quantify that, but I'll say, but I'm going to say, like if I'm in Haiti, or if I am in, like in the sub-Saharan Africa, I'm not going to wait. I'm going to recommend that they initiate therapy. You know, so if you're just in places where HIV is the incidence is very high, and again, that can vary, but I would err on the side of precaution and proceed forward. I know I'm being a little elusive there. I'm not giving you a number intentionally, but there's so much judgment involved. I hate to even say a number.
Yeah, when we're dealing with an HIV, you know, which is a potentially lethal infection, then the incidence of high gets much, you know, quantifying it as a high risk gets much lower.
Yeah.
If you were dealing with something that was curable, easily curable, or not potentially lethal, then the risk factor goes, you know, way down. But dealing with HIV, where the risk factor is very high, and you know, and Jody, as you're well aware, and the rest of you are out there that work in this field are well aware, it's not unusual in many countries to have the rate in excess of, of 10%.
Okay, so we talked about the general format of therapy. This is a SPLA soldier. I was just impressed. He is a pretty tall guy. I guess he must be Dinka. I'm sure he must be of the Dinka tribe, but pretty impressive stature. You'll see a lot of the SPLA around South Sudan. In terms of treatment, the preferred regimen for Samaritans, PERS, and it's endorsed by actually a number of organizations, is tenofovir, and I mentioned that earlier as it is potentially toxic to the kidneys, but again, the incidence is very low. The patient you really want to be worried about with tenofovir if they have baseline kidney impairment. So that's the thing you want to know is if you have a patient with chronic renal insufficiency, then that's not the drug for them. And I don't know this for a fact, but I would surmise that this patient that I described to you earlier, he probably had some renal insufficiency, and either they didn't ask him or he didn't know it, and he took this drug, because that's when tenofovir does its bad thing on the kidneys. That's when it has an impaired impact on the kidneys, is when someone has underlying chronic renal insufficiency. But the preferred regimen is tenofovir plus emtricitabine plus rituximab, and the first two are the nucleoside reverse transcriptase inhibitors, and then rituximab is the protease inhibitor. And this is taken for 28 days, and is generally a pretty well tolerated regimen. AZT zidovudine was initially one of the preferred regimens, but it causes very acutely, in a high incidence of patients, GI toxicity. So that's sort of fallen out of favor. So that's why we use this. I will comment too, the first two drugs, tenofovir and emtricitabine, they are available commercially as a unified drug called Truvada. A lot of you are probably familiar with that too. So it's a relatively easy regimen with, you can take Truvada and rituximab, so just two drugs for 28 days. But there's a number of alternative regimens. Again, let's say if you have a patient with renal impairment, a perfectly acceptable regimen is you can just drop the tenofovir. It's 2-drug therapy, but it's still highly efficacious, and just use the emtricitabine and raltegravir. And that's what we're going to be sending out to the field is those 3 drugs. So that way it gives us the flexibility of we'll only provide, have 3 drugs because, it gets difficult if you start putting an enormous amount of drugs in there. But there's 2 regimens in those 3 drugs. You can, again, use tenofovir, emtricitabine, and raltegravir, or you can drop the tenofovir and just use the 2 drugs. But there's some other regimens there, tenofovir plus emtricitabine plus atazanavir and ritonavir. Those are 2 protease inhibitors at the end there. And then the next one is tenofovir, emtricitabine, darunavir, and ritonavir. And then finally stabudine, which is, I believe, D4T, and then lamivudine, 3TC, and raltegravir. So you don't need to know all those drugs, but those are alternative regimens. There's a lot out there. But we do use this regimen right here, as I mentioned. This regimen right there. This slide defies all the rules of PowerPoint, but it is so informative that I wanted to include it. I hope everyone can read it out there. I'm challenging us guys 50 and older. But let me see if I can make sense of this slide for you, because it's really a very, very informative slide. So this is all totally in regard to treatment for hepatitis B. So as I said, the thing that you want to remember with hepatitis B, what's paramount is what is the surface antigen status of the source patient, and what is the vaccine and vaccine response of the exposed patient. So with that in mind, if you'll look at the top, it says treatment. Let's see if I can. Is that the pointer? No. That's a line draw. Okay. Anyway, I'm not going to be able to clear that now. But anyway, if you look at the top, it says treatment when the source is, and in the first column it says surface antigen positive. If you're dealing with and then so at the top, this is all in regard to the source patient, and this here, we're on the side there, it's in regard to the exposed patient. So at the top of it, it says if the surface antigen, if the source patient is surface antigen positive, that is, they have active hepatitis B, if the exposed person is unvaccinated, then you immediately want to give the exposed patient hepatitis B immune globulin times 1 dose, and then you start the hepatitis B vaccination series. If the source patient is Hep B positive and the exposed person is a non-responder, then you actually want to give Hep B immune globulin twice. You want to give it immediately, and then you want to repeat it in a month. And then you also want to reinitiate revaccination. And then finally, if the exposed person does not know their antibody response, in other words, they've been vaccinated, but they've never tested their antibody titer, and that would probably be a lot of us listening today, then in that situation, then you want to give the hepatitis B immune globulin, and you want to give them a vaccine boost. If the source patient tests negative, then of course no treatment is necessary. If the source patient gets away without being tested, and you're dealing with a person that is unvaccinated, then you would just initiate the hepatitis B vaccination series. If, again, the source patient is unknown and you have a patient that has been vaccinated and it's a known responder, of course you do not need treatment. If you're a known non-responder, that is, you've been vaccinated but you do not mount sufficient antibody, then you treat as if the source patient were hepatitis B positive. In other words, you would give this patient hepatitis B immune globulin twice, immediately and then in a month, and then you would initiate revaccination. And then finally, if the exposed person has been vaccinated but does not know their antibody titer, then you test the exposed person for their antibody titer immediately. If they have sufficient antibody titer, then no treatment is necessary. If they have inadequate titer, then you reinitiate vaccination. That's a lot of information there. I encourage you to look at this again on the recorded session because that is everything critical for treatment of hepatitis B. Let's see, I think there might have been a question over here. Any questions? Yes, Cindy.
What percentage of the population are non-responders?
It is very, very low. I actually meant to look that up. Honestly, I don't know the answer. Does anybody know the answer to that question? What percentage of persons are non-responders? Again, it's very low, but I don't know. Mark, do you know? Okay.
How many locations where you have workers, medical workers, could you even get the hepatitis B antibody?
Well, funny you should ask. Right now, I mean, it would be very small. We're taking steps to make that available now for Samaritans first. We're implementing it right now because it's just not been addressed in the past. But I would say extremely low. Yes.
So you'll have prophylactic for both HIV and the hepatitis C in the field.
Yeah. The kit that we will send out will contain the antiretrovirals that I mentioned, the tenofovir, emtricitabine, and the rtalgravir, and then we'll also have we'll have the Hep B vaccines, and we may or may not have immune globulin too. So, but if we don't, we will have locations where those will be available. So,
the thing we run into in the field, of course, is storage capacity and availability of cold storage for some of these things.
Yeah. So now, in regard to hepatitis C treatment, as we discussed earlier, there's not an option for clear screen up there. For hepatitis C, there is no treatment, as we discussed with the question previously. There is, again, no proven effective PEP treatment for persons exposed to blood and body fluids from a Hep C positive source. Proper diagnostic surveillance is recommended, as we mentioned earlier, to identify possible seroconversion early. And if the patient does seroconvert, then of course you want to initiate antiviral therapy as soon as possible. Just for a historical perspective, it used to be that just interferon was the sole therapy for hepatitis C, and then they added ribavirin, and since then they've now added several other antivirals, boceprevir or telaprevir in combination with ribavirin and interferon. But those are very, very effective antiviral therapies now, where you can clear the virus in a very, very high percentage. Like I think about 80% of people that go on the full regimen clear hepatitis C now if you catch it before it goes into cirrhosis. Here's another buddy from Yida refugee camp. So that's really that's it. I know I went over a lot of material quickly. Does anybody have any parting questions or comments? Or I'd also, if we could maybe briefly mention, what is SP's action plan? And we talked about that all throughout this conversation, that we have finally, we're making the final touches on our post-exposure prophylaxis protocol, and we'll be deploying these PEP kits to the field, especially we're providing active medical care. So, questions or comments?
When are you dispensing these PEP kits?
We're going to take our first 3 kits this Sunday out to South Sudan. Yeah.
Is it possible to always get a rapid HIV test in these field sites, or
a lot of them, I shouldn't say a lot, a number of them, where they're providing health care, they already have them, but these kits, test kits, will be, we're going to have all the kits in the test kit, Any other questions?
You give rabies vaccine in those kits?
Well, that's, at this point, that's not, it's just addressing Hep B, C, and HIV. So at this point, no, sir. But I do recommend that if anybody is spending any length of time out in the field, Samaritan's Purse highly recommends that they be vaccinated for rabies, because animals out in the third world, especially domestic animals like dogs and cats, they're not going to be vaccinated for rabies as they would in the States or Canada or the UK or, so.
We got a couple of comments.
Okay. What is the level of evidence for the 28 days for HIV treatment? That's a great question. Actually, nobody knows. There has been a number of, just anecdotally, there's been a lot of people that have been exposed, and that is intuitively has worked. But they're doing studies to see if shorter lengths of time can work. But of course, we want to be really careful about that. We know that a 1-month regimen works, but it could certainly change as we go forward.
I have a comment, Miss Mary Lou.
Hey, Mary Lou.
Hi, this was good. Thank you. I wanted to make sure that people know that Dr. Linda Mabula worked very, very hard along with the International Health Team on putting the protocol together, and she no longer works for SP, but still helps us out a lot, and she just needs to have a lot of credit for that.
Yeah. In fact, I want to add to that, and I'm glad you said that, Mary Lou, is I want to recognize Tom Wood, Mary Lou Fisher, and Linda Mabula, as they put in an enormous amount of time to make this a reality. It was a daunting task, and we're not quite finished, but I applaud their efforts. They spent a lot of time working together to do that, and I really appreciate it. So thank you, Mary Lou, for pointing that out.
All right, if there's no further questions, I want to thank you all for joining us today. We're kind of excited about next week because we're going to have Dr. David Hoover going to be speaking to us. He's a much experienced pediatric surgeon, and his subject is going to be Pediatric Surgeon Lessons Learned from 20 Years Experience in Kenya. So I would invite you back next week. Lance and I will both be in South Sudan. So we're not likely to be able to call in because we're going to be in the field, but I would, encourage you to join in and then support Dr. Hoover as he gives his presentation. So thank you for